Welcome. Pulmonary function test is my topic for today. Patient instruction prior to PFT, no heavy meal prior to the test, avoid smoking for 4 to 6 hours, no alcohol at least 4 hours prior, lose comfortable clothing, avoid strenuous activity before the test, avoid oral bronchodilator since morning, avoid SABA for 6 hours, LAVA for 12 hours, and ultra long acting LAVA for 24 hours. Here we see the spirometer, what we need for standardization, age, sex, height, weight and ethnicity of the patient. This is the lung physiology. Patient is now in the tidal volume. Now asked for deep inspiration and he or she will reach it to the level of inspiratory reserve volume. Then ask for total and complete expiration. Air is blown out, or she will aim into the level of expiratory reserve volume, and after that complete come to the baseline tidal volume and we will reach to the level of tidal volume. So if we sum up the expiratory reserve volume, tidal volume and expiratory reserve volume, we will get the vital capacity roughly 4.8 liter in male, 3.1 liter in female, and the air which is present in the lung cannot be blown out after expiratory reserve volume into residual volume roughly around 1.2 liter. If we sum up the vital capacity and residual volume, we will get the total lung capacity roughly 6 liter in male and 4.2 liter in female. Here we see the formation of the inspiratory loop when the patient is being asked to breathe in from residual volume. He or she will end to the level of total lung capacity. Here we see the patient is breathing and breathe in from residual volume to the total lung capacity. Then has been asked for complete and forceful expiration as quickly as early as possible. We will get the expiratory loop also. So in the expiratory loop we can see the peak. This peak is the peak expiratory flow rate, and from there up to the level of residual volume we will get the forced expiratory flow 25, 50 and 75. This is the percentage of vital capacity. So from total lung capacity up to the residual volume we will get the forced vital capacity. So inspiration starts from residual volume, ends at the total lung capacity, and expiration starts from the total lung capacity, ends at residual volume. And the area in between is the vital capacity. And the peak expiratory flow rate, the spirometric value is liter per second. If we multiply with 60, we will get the liter per minute peak expiratory flow rate value in peak flow meter. And this is the FEF 25, 50 and 75% of the vital capacity, which is found in the descending limb of the expiratory loop. Here the spirometry of the normal person. First, she has been asked for full inspiration followed by complete and forceful expiration. What we get? We will get the volume time curve on the left side and the flow volume loop in the right side. In the volume time curve we can see the forced vital capacity has been measured, and the FEV1, that is the forced expiratory flow and the amount of air which has been blown out in the first second of the respiration, that is FEV1. The ratio of FEV1 and FVC is 81%. And the flow volume loop in the right side we can see a bell-shaped loop is there, and the upper portion of the loop is the expiratory loop and lower portion is the inspiratory loop. Now come to the patient who is suffering from obstructive airway disease. Here he has been asked for same from anywhere, total deep inspiration followed by complete and forceful expiration. What we see on the volume time curve is the curve here. The FEV1 FVC ratio is relatively reduced. It is 57.5%. FEV1 is reduced in obstructive airway disease. On the right side we see the red-shaped curve loop here. In the expiratory loop, what we see? A characteristic concavity which is shown by the red arrow. This concavity is very much characteristic of obstructive airway disease. Now come to the PFT parameter, essential parameter of spirometry, the forced vital capacity, FEV1, FEV1 by FVC ratio, and forced expiratory flow 25 to 75%. Essential parameters of body plethysmography, TLC, RV, RV-TLC ratio. Essential parameters of diffusion, DLCO and DLCO VA, that is alveolar volume ratio, that is KCO. Pyrometric accuracy, how can we accurate the data? Patients should perform at least 3 trials of an FEV1 FBC value should be each other, close to each other, which should be between 150 ml or 5% to each other across the trial, and the best one should be considered. Quick and forceful start of exhalation following a full inspiration. Full and complete exhalation, which is usually takes 6 seconds or more. No coughing, smooth bell-shaped curve, smooth bell-shaped flow volume loop formation is characteristic. Normal value of the pulmonary function test is the important slide. FEV1 FBC ratio should be taken as actual value. More than 70% is normal. FEV1 percentage of predicted value 80 to 120%. FBC percent predicted value 80 to 120%. FEF 25 to 70%, predicted value 60 to 120%, total lung capacity 80 to 120%, RBTLC ratio, as it is ratio, we have to consider the actual value. It should be less than 35%, and DLCO percentage of predicted value 80 to 120%. So in ratio, FEV1 FBC ratio and RBTLC ratio, we have to consider the actual value, and the other cases, this should be considered as percentage of predicted value. Useful spirometric parameter, FEV1 FBC actual value in pre-bronchodilator study is needed to diagnose obstructive airway disease if it is less than 70%, and post-bronchodilator increment if it is more than 70% suggests reversible obstructive airway disease. FEV1 actual value increment from pre to post bronchodilator state is needed for asthma diagnosis if the increment is 12% and 200 ml. FEV1 percentage of predicted value in post bronchodilator study is needed for COPD severity staging is 80% or more, 80 to 50, 50 to 30 and less than 30. Stage 1, 2, 3, 4, which is very severe, is the stage 4. Now come to the FBC value. FBC value will be reduced in advanced obstructive airway disease, that is less than 80%. RBTLC value will be increased in obstructive airway disease, that is more than 35%. FEF 25 to 75% is reduced in small airway obstruction, that should be less than 60%, like respiratory bronchiolitis. FBC and TLC value will be reduced in restrictive lung disease, that is less than 80%. ILD curve loop, this is the volume time curve in pulmonary fibrosis or interstitial lung disease. You see the characteristic volume time curve is same like the normal, but the force vital capacity is reduced. FEV1 is also proportionately reduced, and FEV1 FBC ratio is more than 80%, that is normal. In the right side we see the volume loop. The loop is there, is at the loop of the miniature of the normal curve, normal loop, almost same to the normal loop, but the size has been reduced. This is due to decreased vital capacity. So it is the miniature of the normal curve. Maximum voluntary ventilation, patient nose is clipped and patient has been asked to hold the airflow transducer vertically. Initially breathes normally, then asked to breathe as quickly as possible, as for 12 seconds, then multiply it with 5, so can get the 1 minute value. Maximum amount of air breathed in and blown out per minute is calculated as MVB. Normal MVB value in female 80 to 120 liter per minute, in male 140 to 180 liter per minute. Decreased MVB occurs in obstructive airway disease, restrictive lung disease, chest wall neuromuscular weakness, poor effort. MVB equal to FEV1 into 35. This theory applicable in normal person and in obstructive airway disease, but that it is decreased than FEV1 35 multiplied value in restrictive lung disease, chest wall neuromuscular weakness and poor effort. This is the DLCO chamber. We use the gas carbon monoxide 0.3%, helium 10%, oxygen 21% and nitrogen rest of the gas. Needed percent hemoglobin for standardization of the report. Here we see the DLCO mechanism. Patient is asked to exhale completely up to the level of residual volume. The gas chamber is present, blue color here, contains carbon monoxide and helium preliminary, and the valve is closed here. Then patient is asked for complete and deep inhalation, and after dilation the valve is open and the air and the gas which present in the gas chamber, particularly the carbon monoxide and helium, enters into the lung and diluted with the residual volume of air. Then he or she will be asked to hold the breath for 10 seconds for diffusion of the carbon monoxide through alveolo-capillary membrane, and after that patient is asked for exhalation into gas analyzer, and gas analyzer is analyze the carbon monoxide diffusion. DLCO concept. DLCO is the diffusion capacity of the entire lung. Decreased DLCO occurs in alveolo-capillary membrane drainage or when the lung volume is reduced, as occurs in smaller lung, collapsed lung or pneumonectomy. DLCO VA ratio is the Casio alveolar volume. Reduced lung volume, as occurs in small lung, collapsed lung, lung dissection, DLCO will be reduced but Casio will be normal. But when the parenchymal lung damage is in alveolo-capillary membrane damage, in emphysema or interstitial lung disease, DLC will be reduced and Kc will be also reduced. This is the body plethysmography chamber, a closed chamber. Patient is sitting here using Boyle's formula. We will get the TLC, RV and RV-TLC ratio. This is the asthma patient PFT report. What we see, FEV1-FVC ratio in pre-bronchodilator state is 66%. It is less than 70, so it is obstructive airway disease. In the post-bronchodilator state, it is 73, more than 70, so it is reversible obstructive airway disease, likely to be asthma. Let us see the FEV1 value. Whether there is increment is the pre-bronchodilator, it is 2.16 liter. In the post-bronchodilator, it has been increased to 2.68 liter and 24% increment. So it is more than 200 ml and more than 12% increment. So it is likely to be a case of asthma. Here, what to look for in asthma cases? FEV1-FVC ratio and FEV1 increment. And this is the curve. The red shaped flow volume loop is the pre-bronchodilator study, and the blue shaped loop is the post-bronchodilator study. You see here the arrow denotes the concavity is more prominent in the red shaped flow volume loop, and concavity is less prominent in the blue shaped flow volume loop. This is the COPD-PFT report. Here we see FEV1-FVC ratio in the actual value. In the pre-bronchodilator state, it is 45, so it is less than 70, it is obstructive airway disease. In the post-bronchodilator stage, it is 43, no improvement, so it is irreversible obstructive airway disease. Let us see what happened. The RV-TLC ratio, here the actual value is to be considered. It is 67%, this is more than 35%, so it is likely to be COPD. And the diffusion value, what is the diffusion carbon monoxide DLCO value? It is 26, it should be more than 80%, so it is a case of COPD. So what to look for? In COPD, we have to look for FEV1-FVC ratio, RV-TLC ratio and DLCO. This is the ILD-PFT report. What we see first, FEV1-FVC ratio, it is more than 80%, here it is 82%. So it is not a case of obstructive airway disease. So next we have to see for the forced vital capacity. What is the value here? Percentage predicted value is 52.9%. It is less than 80%. So it's likely to be a case of pulmonary fibrosis. Next come to the total lung capacity. Here the value is 58.9. It is less than 80%. So it may be a case of interstitial lung disease or pulmonary fibrosis. Let us see the DLCO value. What is the value here? It is 55.2%. It is less than 80%. So DLC value has been reduced. So what to look for in case of suspected pulmonary fibrosis? We have to first look for the FEV1-FVC ratio. Next, forced vital capacity. Next is the TLCO, and finally DLCO. Diagnostic algorithm: any breathless patient, first look on the FEV1-FVC ratio. If it is less than 70%, we have to think from obstructive airway disease. 15 minutes after bronchodilator, if it is more than 70%, it is suspected asthma. Post bronchodilator increment, if any, FEV1 increment 12% and 200 ml, asthma confirmed. On the other side, if the OAD, in case of OAD, if the value of FEV1-FVC ratio is less than 70%, in spite of having the bronchodilator, It's likely to be case of COPD. Look on the DLCO value. If the DLCO value is normal, it is chronic bronchitis. If the DLCO value is reduced, it is likely to be due to emphysematous change where alveolo-capillary membrane damage occurred. On the other side, from beginning, if the FEV1 FVC ratio is more than 70%, look on the FVC value. If it is reduced less than 80%, look on the TLC value. It is less than 80%, likely to be a restrictive lung disease, look on the DLCO. If the DLCO value is normal, it is most likely the neuromuscular weakness, chest wall defect or pleural cause. If the DLCO is low, most likely pulmonary fibrosis. On the other side, if the total lung capacity is more than 80%, it is most likely due to poor effort. On the other side, if the forced vital capacity is more than 80% and FEV1 ratio is more than 70%, it is normal pattern. Now come to the DLCO value. If the DLCO value is low, it will be case of pulmonary hypertension or pulmonary embolism. If the DLCO value is normal, it is likely to be a normal rebound. Post-BD bronchodilator FEV1 more than 12% and 200 ml increment, but FEV1 FVC is still less than 70%, suggestive of reversibility with persistent airway obstruction as occurs in asthma COPD overlap syndrome. So, if we get FEV1 FVC is still less than 70% as per post bronchodilation, but there is increment of the FEV1 12% and 200 ml, we can say the both component is present. COPD component and asthma component both are present. It is asthma COPD overlap syndrome. Take home message: in spirometry apport analysis, first looked on the pre-bronchodilator FEV1 FVC percentage, whether it is less than 70% or not. If so, it is obstructive airway disease, maybe asthma or COPD. Next, look on the post-bronchodilator FEV1 FVC ratio. If it is more than 70%, it is reversible obstructive airway disease, likely to be asthma. Next, look on the increment of the FEV1 actual value from pre-bronchodilator to post-bronchodilator state. If it is more than 12% and 200 ml, it is a definite case of asthma. On the other side, if bronchodilator FEV1 FVC more than 70%, look for forced vital capacity. If the forced vital capacity is 80%, less than 80% of the predicted, it may be a case of restrictive lung disease, maybe parenchymal lung disease or extraparenchymal lung disease or poor effort. Now, if the TLC value is less than 80% of the predicted, it is restrictive lung disease, may be parenchymal or extraparenchymal. If the DLCO value is low, it is lung parenchymal disease like pulmonary fibrosis. If the DLCO is normal, it is extraparenchymal restrictive defect like neuromuscular chest wall defect or kyphocoliosis. Thank you.